Okay, our next sort of discussion, it's an educational session, VHL 101 and genetic counseling. And some of this has already been introduced in the first session, but I wanted to introduce Dr. Qian Qin, who is one of our lead VHL providers, and I think sees probably more VHL patients than any of the other of us in adult medical oncology. And you've already been introduced to Remington Fenter, and they're going to sort of go through these topics, just so nuts and bolts, because everybody's at a different place in their journey with VHL. Some people have had a lot of experience and, could write a whole book about their journey with VHL and know everything about it, and others are new to this. So we'll start this off with Dr. Qin.
Well, thanks so much for joining us this morning and the fantastic discussion just now. I'm Janie Chen. I'm one of the cancer doctors here at UT Southwestern. But as Dr. Courtney said, I see a lot of our VHL patients and actually share a lot of patients with our pediatric colleague. And so this session is meant to kind of just go over the 101s of VHL, right? Its biology, the manifestations, and then Remington, our fantastic genetic counselor, will go over kind of the genetic counseling and surveillance portion. So to start, let's talk about disease biology for VHL. And so how often does it occur? It's as the people in this room know, it's quite an uncommon disease, right? It occurs in about 1 in 36,000 individuals. How does one get VHL? Remington, again, we've had this discussion that was started already, that it is hereditary. And so what that means is it's usually passed down from parents to children. Again, in 20% of the time, that's not the case, but for majority of patients, there's usually a family member with VHL diagnosis. And how is it passed down? It's often passed down in a autosomal dominant pattern. And so what that means is we each have two genes in our body. We get one from mom and one from dad. And in autosomal dominant pattern, you just need one mutated VHL gene to have the manifestations of VHL. And so that means if we have an affected father, unaffected mother, there's about a 50% chance that their children will have VHL. And there are exceptions to this pattern, which Remington, I'm sure, can answer questions regarding. So then what drives the signs and symptoms of VHL, right? It's that mutation in the VHL gene. But why does that mutation in the VHL gene drive those signs and symptoms? So this is what we think one of the main pathways for which we have those signs and symptoms manifest. So just to kind of get our understanding, in normal oxygenation status, right? You're getting enough air to your body, to your vital organs. We have these proteins called HIFα and HIFβ. And the HIFα in normal oxygenation, they actually get degraded by the body. So they don't combine with HIFβ. And that degradation process has something called the PVHL ubiquin ligase complex. It's a very complex word for basically something that helps to this process of degrading the HIFα. Okay. Versus in low oxygen state, your body is saying, I need more oxygen. I need more oxygen for my vital organs. So in those cases, the HIF-alpha actually does not get degraded. And so that HIF-alpha accumulates and it binds with HIF-beta. And that combination of the two then leads to downstream transcription of different genes that helps with things like building blood vessels to supply those oxygens to organs, or resisting cell death, what we call resisting apoptosis, or potentially helping some of these cells spread to other parts of the body. And so in normal conditions, that's what the body is supposed to do. However, when you have VH gene loss, the PVHL ubiquin ligase complex is not working well. So then you have an abnormal accumulation of HIF-alpha, an abnormal combination with HIF-beta, an abnormal increase in all these downstream genes and proteins and things that can cause cells to grow more, blood vessels to form, and then cause the signs and symptoms of VHL syndrome. So what does that look like, right? The disease manifestations of VHL. So as we've learned, it's a multi-organ. It affects multiple organs in the body from head to toe. And so this is kind of a summary of the types of tumors and cysts that can develop. We'll kind of go over each one in a little bit more detail. So first is in the eyes. And in the eyes, patients can develop what's called retinal capillary hemangioblastoma. So this is a type of eye tumor that can occur in the retina. And so if we think about the eye, it's a circular organ. And we have in the very front the cornea, and then we have the pupils. And on the back, there's a layer of cells that creates the retina. It's what our eyes, they shine light and such onto the retina, which is what translates it to the brain. So we have the perception of sight, so we can see. And so these tumors can occur on the retina of VHL patients. And what happens is when they occur on the retina, we'll see, when you go see the eye doctor and they shine a bright light and they take a look inside the eye, that's what they're looking for. They're looking at the retina. And often what you'll see is there's a very tortuous kind of enlarged blood vessel that then leads to an orange reddish lesion. And that lesion is the retinal capillary hemangioblastoma. And that lesion, it can actually stay stable for a long time, or sometimes even shrinks a little by itself. But other times it can really grow. And so for a lot of patients, they might not actually feel anything when you have a lesion there, but when it grows and causes issues, there can be vision issues, and there could be vision loss because this layer, the retina, can actually peel off, what we call retinal detachment, and that can lead to vision loss. And so that's why it's so important to see the eye doctor, right, to get these exams and make sure that either the patient's not developing retinal capillary hemangioblastoma, or that if they are, it's monitored closely and treated as appropriate. Oops. The next one is in the brain and the spine. And so these are called the central nervous system or CNS hemangioblastomas. And so they usually occur in the terrible with the pointer. They usually occur here in the brainstem and cerebellum, or they can occur on the spinal cord. Okay, they're quite small lesions, but they tend to be multifocal, which means they can occur in multiple areas throughout the brainstem and the spine. And if you can imagine, the brain and the spine, it's a pretty narrow space, right? And so any lesion that develops can cause issues. And because of how important these are to our sensory, our motor function, and our balance, patients can have those type of symptoms. It's also worth noting that when you see a lesion, this is why you get MRIs, right? It's for us to look for these lesions within the brainstem, the cerebellum, and the spinal cord. And sometimes you'll see not only the lesion, but also a fluid-filled component next to it, which is called the cystic component. It's important to know that when we see a cystic component, those lesions tend to grow faster. And in fact, the cystic component can sometimes grow faster than the tumor itself. So often when we see this, we keep a much closer eye. And so to a patient's prior, question about surveillance and scans, which Remington will go into more detail, it's the guidelines and also the patient, right? And so if you're seeing a patient with manifestations, you might be getting those scans earlier, depending on how worried we are as clinicians, right? And so it's important to note that this is why we surveillance for these lesions. The next one is in the ear, and so it's called the endolymphatic sac tumors. And so these can occur kind of in the middle inner ear here. And so we have something called endolymphatic sac and the endolymphatic sac duct. And our ears help us not just with hearing, right, but also with balance. And so patients who get endolymphatic sac tumors, they can have symptoms like fullness or pain, ringing in the ear, or vertigo, which is feeling like the room is spinning. And of course, we can have hearing issues or hearing loss. It's also kind of the area where we have our facial nerves. And so once in a while, you also hear that patients may have facial nerve weakness symptoms as well. These lymphatic sac tumors are excessively rare in the common population, but it can happen in about 5 to 15% of patients with VHL. It can happen both on one side and on both sides. And so they're teeny tiny organs. So we have to tell our radiologists, hey, look out for these tumors because we want to be able to identify them early, right? And so we don't have the complications of hearing loss and vertigo and ringing in the ear, etc. And and so the other thing is patients should be getting hearing tests, right? If we note that the hearing is decreasing, that's a sign that tells us we need to be looking for endolymphatic sac tumors. Okay. Moving down, now we're kind of in the abdomen area. We have what's called pheochromocytoma. And so these can happen on the adrenal gland, which are these tiny little glands that sit atop of the kidneys. And so we have two of them. They usually make hormones that our body needs to function. Okay. One of those hormones normally is actually called catecholamines. They're the adrenaline rush hormones. They're the fight and flight hormones, right? If you're in a stressful situation, and your body is trying to determine what to do next, and you get some adrenaline related hormones that's secreted to help you with that response. But with pheochromocytoma, it's an abnormal secretion of these kind of adrenaline hormones, is what I would call them. And so with pheochromocytoma, patients can actually get too much adrenaline that comes in spurts, which can cause things like headache and sweating and fast heartbeat and high blood pressure. And because it's abnormal and often significant elevation in the adrenaline hormones, it can be quite dangerous because if your blood pressure goes very, very high, your blood vessel is not going to be able to take that, right? And so that's why patients also get screened for pheochromocytoma, making sure your blood doesn't have the adrenaline rush when it's not supposed to. And then coming down onto the kidneys, in the kidneys, we can have cysts and tumors. And so cysts, again, are fluid-filled pockets. They're not cancerous, but there can be often with VHL multiple cysts, and they tend to be bilateral, meaning in both kidneys. And the cysts can be simple, which is just a simple fluid-filled sac, or they can be complex, which means they get septations in the middle. So that cyst becomes compartmentalized into small pockets. And it's important to know that complex cysts can develop into renal cell carcinoma, what we call clear cell renal cell carcinoma. And so again, when we're watching these cysts, if they're becoming complex, we get a little bit more worried and we might look a little bit closer. And then the other side of the coin to that is the clear cell renal cell carcinoma, which is the tumor and the cancerous portion. So usually the clear cell renal cell carcinoma associated with VHL syndrome tends to be relatively low grade and slow growing. But that being said, and it's important to know that when they're less than 3 centimeters, the chance that they'll metastasize or move to other parts of the body is quite low. But that being said, with VHL syndrome, that clear cell renal cell carcinoma can recur. And so, as we've heard, right, you might end up getting multiple surgical resections. There's only so much kidney to resect, right? And so, that's where, again, later we'll be talking about belzutifan and how that can help potentially prevent surgical complications and surgeries for patients. But because of the kind of multiple areas that can occur in the kidney and the recurrence rate, that's why when you have a lot of these, it can cause blood in the urine, it can cause pain and decrease in kidney function. And then the pancreas is kind of in the middle of the stomach, and it's another organ that secretes things that the body needs to function. So there's exocrine and endocrine functions. It secretes pancreatic enzymes, right, for us to help digest food. Secretes insulin or glucagon that helps us with our glucose or sugar monitoring, right? So within the pancreas, we can again get cysts, and we can get something called serous cyst adenomas. They're basically a collection of cysts, tiny little cysts with septations, like fiber septations in between. So these are, what we consider not cancerous lesions, but again, you can have multiple that grow, and if they take over the the pancreas, we can certainly have issues like pain or deficiency in the enzymes that's created by the pancreas. And then the pancreatic neuroendocrine tumors are solid tumors that can also develop in the pancreas. Again, they're usually well differentiated, slow growing, and non functional. But just like with the kidney cancer, there is malignant potential. And so, if we do find pancreatic neuroendocrine tumors, we certainly want to treat it. And the last part is what we call papillary cystadenomas. So these can occur in the broad ligament of female, or they can occur in the epididymis of male. And so broad ligament is a ligament that's next to where the uterus, the fallopian tubes, and the ovaries are. And the epididymis is a small tube-like structure, kind of on top and next to the testicles, that helps to store sperm. And so, as one can imagine, if we have papillary cystadenomas, it can cause fertility challenges for our patients. And so it's something that we really have to keep in mind. Okay. So with that, that's kind of the overview of the potential disease manifestations of VHL syndrome. And I'm going to turn the mic to Remington to kind of talk about the genetic counseling and the surveillance portion.
Thank you, Dr. Chen. So moving on, as I was introduced earlier, Remington Fincher, one of the genetic counselors here with our team in the cancer genetics department. In terms of what makes cancer hereditary, I want to give a brief overview of that too, because we've been talking about the VHL gene specifically, but we are all born with a set of genetic instructions that tells our bodies how to grow and develop. This can also determine our appearance, like hair and eye color, along with our chances to develop different health issues. So our genetic information is broken down into smaller parts and stored in areas called chromosomes. Within those chromosomes, we have the smaller sections that actually make up the genes themselves. When we look at a family where we can see multi-generational conditions, like we saw in the image from Dr. Chen about VHL passing down in a family, if we start to see the same health conditions throughout a family affecting multiple people, we start to wonder if there could be a hereditary cause for them or an underlying genetic reason that's being passed down. In most cancers that develop in people, or sporadic cancers, they're caused by mutations within their genetic information that build up in those cells over time. They start with a normal cell with a normal set of genetic information. They receive damage to the cell from like radiation or chemical exposures, and then a first mutation occurs. Then other mutations develop within that cell line until we get to enough mutations where it actually causes abnormal cell growth and cancer. In terms of hereditary cancers, a person's already born with that first level of mutation occurring in a gene that's typically supposed to protect them from cancer development or tumor growth. Then they develop other mutations caused by damage to those cells over time that then leads to the cancer and tumor development. So in terms of VHL, well, the VHL gene exists on chromosome 3, down towards the bottom of the small arm on chromosome 3. When we look at VHL, it is a tumor suppressor gene. It, as Dr. Chen mentioned earlier, prevents the cells from growing and dividing too rapidly. When it's not functioning properly, it leads to increased cell division and cell growth, new blood vessel growth, as well as red blood cell production or overproduction. Pathogenic or disease-causing variants are detectable in about 95% of all patients who present with a clinical diagnosis of VHL, meaning that there's about 5% of people with VHL that will not have an identifiable mutation within the VHL gene. And we're still learning more about the gene and errors within it or other things that could be contributing to this disease. In terms of de novo, we talked about that earlier, about how most these mutations are passed directly from parent to child, but about 20% of them are newly occurring. And for those newly occurring ones, those people still have a chance to pass that down to their children, but it's much less likely to affect their siblings, their parents, aunts and uncles, cousins, and we're not likely to see a de novo mutation occur more than once in the same family. So if a person has a mutation in one side of the family and one person, neither parent has it, we're not likely to see that pop up in other people within the family other than being passed directly to their children. So in VHL management, our best management recommendations come from the VHL Alliance, as they've worked to devise these screening recommendations and update them on a regular basis. And we make recommendations for screening based off of what we expect or the likelihood of those tumors and features developing in a person throughout their lifetime. And so we don't do all of these screenings early. And throughout a person's age, we might even stop doing routine screening after a certain age if they have never developed any of those symptoms. And in terms of pregnancy, it's always important to do those screens prior to conceiving a child. That way, if a person does have any of these features, they can treat them and handle them appropriately before conceiving, especially in terms of those pheochromocytomas that Dr. Chin talked about, where they can produce those extra levels of adrenaline. For a person who's pregnant who has an active pheochromocytoma, that can really complicate not only the pregnancy, but also the delivery. And a person might have to go through a delivery of that pregnancy in a more advanced setting with doctors and providers that can care for them if they have these sudden spikes in their blood pressure or their heart rates. In terms of other guidelines that have come about, we have the National Comprehensive Cancer Network, which often sets gold standards for care and treatment of not only cancers, but of these genetic predispositions to cancers as well. And in more recent years, they've made more comments on VHL and other hereditary cancer conditions related to neuroendocrine tumors, including adrenal gland tumors and pancreas tumors, along with renal cell carcinoma. And you can see here within their recommendations, they have specifics about what they recommend for the management of tumors in people with VHL. So not only are they making recommendations for screenings, but they're also making recommendations of when people should be considering doing surgical resections, the level of that resection, different treatments, different therapies, even the discussion of adding in belzutifan as far as part of their cancer and tumor management. And not all VHL variants cause von Hippel-Lindau disease, though. So there are other variants within the VHL gene that can occur that don't actually cause VHL disease in a person. There are at least 10 different variants that have been identified that do not cause VHL at all. Instead, they cause familial erythrocytosis type 2, also known as Chuvash polycythemia. And what erythrocytosis is an overproduction of red blood cells. And if you remember earlier, when VHL isn't working properly, one of the things it can do is increase the production of red blood cells. So variants here with reduced VHL function, not complete loss of function, can lead to that causal production of extra or excess red blood cells. The 3 different variants here that are listed are the most well-known variants for this type of condition related to VHL. And I point this out because there might be some people that you come across or that you meet or that you know about who have variants in VHL, but they do not have VHL disease. And if they happen to have one of these known to cause the familial erythrocytosis or this type of polycythemia, then they won't have any of the manifestations of VHL that are classic to the version that y'all are more familiar with. This version of errors in VHL is recessive, meaning having only one abnormal copy of one of those variants in VHL does not cause the familial erythrocytosis or polycythemia. They have to have both copies of their VHL gene affected with one of these Chuvash polycythemia or these erythrocytosis related variants. So it is a recessive condition, not that classic dominant version that we saw and talked about earlier. So when it comes to this, the health risk related to that version of disease related to VHL causes the increased red blood cells or erythrocyte counts, which is what erythrocytosis is. They can also experience headaches and dizziness, nosebleeds, shortness of their breath, and then abnormal blood clots, which can lead to things like heart attacks or strokes for them too. In terms of genetic counseling related to VHL, this is performed either through a blood test or a saliva sample. It usually takes 2 to 4 weeks for us to get the results back from these types of testing. And it's not nearly as expensive as it had been in the past, with many laboratories doing self-pay testing without going through insurance at all. That can range between $250 to $500. And for people who may have had testing years ago or more than 15 years ago, the testing has come a long way and has really been updated since then. In doing genetic counseling, you would see a genetic counselor who can answer your questions related to, will my insurance cover my genetic testing? Am I at risk for insurance discrimination related to my genetic test results? And luckily in the United States, we have a federal law called GINA, or the Genetic Information Non-Discrimination Act, which states that our genetic test results cannot be used by employers or by medical insurance companies to deny coverage, change our our benefits or lead to changes in our job status. How will these results help me and my family in understanding our own health risk and prevention for those health risks, as well as who is the best person in the family to undergo that genetic testing? I want to talk about RNA analysis. So we talked a lot about genetics and DNA, or the VHL gene. And as Dr. Chen talked about, the VHL gene leads to production of the VHL protein. But before it gets to the VHL protein, it has to make RNA. And RNA is kind of like the cliff notes of our genetic information. It's the shortened version that provides the first level of instruction from that basic material or basic instructions. So RNA genetic testing enhances our understanding of DNA genetic testing by clarifying the functional effects on cancer susceptibility gene variants. And it tells us if some of these variants that we are less clear on will actually cause any errors in a person's production of that gene to RNA and then to protein. So some people who might have a clinical diagnosis of VHL may not have any underlying identifiable genetic cause on their previous testing, and updated testing that could include RNA analysis might show us what the RNA is doing. Not all laboratories that do testing on VHL include RNA analysis. It's something that's only been more recently added in, and it can affect that variant identification and its classification. And it produces both a functional test, a qualitative and a quantitative test, seeing if it's reducing the amount of RNA being made from the gene as opposed to just seeing the quality of it too. It does not affect the cost or the turnaround time for genetic testing for these genes, but it's not available for all sample types. For this type of testing, we have to use blood samples to do it. There are laboratories, when they are looking at it, they're looking for changes that may not just occur in the main parts of our genetic information that we have traditionally thought about being the most important, which are our exons. These are the parts that are made directly into the RNA, but they can also detect essential places within the rest of the genetic material, the introns, that can be used in the editing for our RNA, or affect whether we get the ends of the exons cut properly and made into the RNA that we need them to. So it can identify clinically significant variants that then affect the production of RNA that would have been missed otherwise through traditional DNA-only based testing. Different laboratories have used this to decrease the rate of uncertain variants in their test results. And then in terms of our clinic space here at UT Southwestern, I mentioned earlier, we have a genetic cancer prevention clinic. This provides specialized care for our patients, similar to what DEO does in the clinic for our VHL patients. We do this for patients with other genetic conditions related to cancers as well, going over their family history of cancer, talking about family history for people who or personal history for those who may not have developed any of these manifestations. We see people who are on long-term survivable care for disease, or those who are in remission from cancer. We don't typically focus on people in this clinic who are undergoing active treatment for a cancer itself. In terms of our VHL patients who might have like a renal cell carcinoma who are undergoing long-term surveillance, we could see them in this clinic too. At the clinic, they meet with a genetic counselor who will talk about any additional testing or updates that might be helpful for them, give them specific information about their variants, clarify if it's related to see something like a type 1 versus type 2 version of VHL, updating their personal and family history so it stays up to date in their medical record, coordinate their care if they're not receiving all of it, provide additional resources or research opportunities, and then offer testing to their relatives, and provide letters of how to share that with their relatives and get them in for testing as well. We can provide genetic counseling and testing for anybody who's within the state of Texas at the time of it through both in-person or telehealth appointments. And we also take self-referrals, so people can refer themselves to this clinic just by calling our office number. And that's the end of our section, and Dr. Chen and I can take any questions that y'all have for us.